Now I would like to turn things over to Terry Hill, Senior Advisor for Rural Health Leadership and Policy at the Center, to introduce today's speaker and to kick us off. Terry?
Thank you very much, Kaylee, and good morning, everyone. Today is the fourth and final segment of our four-part series that is really looking at kind of crafting a response to COVID-19, the pandemic itself. And in our three previous webinars, we've looked at telehealth and the rapidly increasing role telehealth is playing, just astounding growth in this area. And our observation is that we're fully capable now of doing infectious disease in patients' homes, as well as treating infectious disease in hospitals and clinics. And so telehealth is absolutely booming. Payment is being aligned right behind it. And so a lot of the obstacles that were there before are being removed. So part of our advice here at the center is to look very carefully at developing a telehealth capacity if you are a rural hospital, and that it's going to be essential year, 2 years down the road to have that sort of capability within your hospital. We then looked at finance, and Ralph Llewellyn from iDaily Group basically did a preview of a document that we now have available, which really looks at all of the elements of the COVID-19 funding that has come out and the relevance to rural hospitals. So I noticed that the American Hospital Association has been promoting this. It was developed through the center by, as I mentioned, Ralph Llewellyn. And it just basically did things to look at to both maximize your funding that's available with COVID, and then secondly, what to be careful about. And there's repayment attached to some of this as well. So I refer you to a document that's certainly on our website, the center's website, which is ruralcenter.org. Our third segment, which just took place last month, we had Lee Elliott, who's, in our opinion, probably one of the very best HR consultants, talking about workforce and the impact that this pandemic has on the workforce itself, the already very challenging kind of task of trying to keep our workforce resilient, motivated, et cetera. And that was last month. And today's webinar, we're going to be looking at protecting our older and most vulnerable patients. One of the things we know is that the impact of the COVID-19 pandemic has been absolutely devastating on our long-term care facilities. I know we're based in Minnesota, although we work in every state in the country. And I know that in Minnesota, well over 3/4 of all the deaths that have occurred in long-term care facilities. That's kind of a high number from a percentage standpoint, but it really brings to mind some of the issues that we've had historically in our long-term care facilities, and the gap between the transitions of care between acute care coming out of our hospitals into nursing homes, into assisted living facilities, into home care and hospice in that regard. So those, I think part of our issues in terms of the devastation in long-term care facilities has to do with processes and kind of inadequacies in our long-term care system, just basically in general. Another big issue that came up, and why we chose long-term care for this final topic, is that the value-based models, so the accountable care organizations, the rural ones, are reporting a significant cost and a lot of waste and frankly some bad quality that's occurring in the nursing homes, particularly the independent nursing homes. And the Illinois Critical Access Hospital Network's Accountable Care Organization reported this was one of their major problems, that it really ate into their quality scores. And then secondly, it was very costly, and there was huge variance in terms of cost as well. So kind of that combination of factors led us to choose this topic. And in that regard, we in the spring held a national summit meeting looking at long-term care and post-acute care. And we chose Louise Bride, who's a principal with the Stroudwater Group, to help write that report. And actually, Louise is an expert in long-term care and post-acute care. And we're kind of on the verge of publishing that long-term care report. And again, it's going to really address some of the issues that I've already mentioned. Louise is here on this webinar to talk about that summit meeting, but also to address some of these historic problems and to give you some ideas about ways we could provide improvements. So with that, Louise is having problems with her video, so she's here basically to speak to us, but we're not going to be able to see her. I'm going to turn things over to Louise. And first of all, Louise, I want to thank you for your role in producing this report, but also the fact that you're willing to be here and help share your wisdom and experience with our Nebraska hospitals.
Thanks, Terry, and good morning, everyone. I'm delighted to be here. As Terry said, I am with Stroudwater Associates, which is a small healthcare consulting firm based up in Portland, Maine. Stroudwater has been doing healthcare consulting for 30 plus years and works extensively in the rural communities in rural America. And I've had the opportunity to do quite a lot of work over the last 9 months working with a colleague in many critical access hospitals and small community hospitals. I've been with the firm for about just over 7 years, and I have a clinical nursing background, a master's in health administration, and I have been in healthcare my entire career. I've really had an opportunity to do a range of work during my time at Stroudwater. I had a considerable health plan background prior to joining Stroudwater, and in particular had some experience working with a Medicare Advantage special needs plan. And we partnered with many nursing facilities across the country, which gave me a real appreciation for the work required to really serve that vulnerable population. I have had a chance to work with hospitals of all sizes at Stroudwater, but particularly, as I say, the last 9 months or so, I've been very focused on working with a colleague to perform quality assessments, working with small rural community hospitals and multiple critical access hospitals. I've also have a particular interest in primary care, and so I'm interested in clinical models that really integrate primary care for individuals who are in a skilled nursing facility setting. And also have done quite a bit of work around care management, coordination of care, transitions of care, working from really all perspectives, working with hospitals, accountable care organizations, and health plans to help them to either develop a care management program or to evaluate and help with performance improvement of care management. So I'm really delighted I was very pleased to be a part of the Post-Acute Care Summit in May, and I really am delighted to be able to spend a little bit of time talking with you all this morning. As Terry mentioned, the summit was convened in May. We really looked, the goal was really to look at issues and challenges related to post-acute care, as well as to spend some time brainstorming and identifying potential strategies and solutions. And as you will see when we get into that a little bit farther in the presentation, the discussions were wide-ranging and really looked at very practical, local, and patient-level solutions, as well as consideration around policy at the federal level. And you see here some of the objectives. As I've mentioned specifically, as Terry and I've already mentioned, identifying problems and issues related to rural post-acute care and aging services, and in the particular focus as Terry mentioned, on the interface and the coordination between post-acute care providers and rural hospitals. We talked, as I say, around strategies to improve coordination of care, and also looked at some ideas around new models to better support the interfaces between hospitals and post-acute care organizations and communities to improve coordination across the full continuum of care. And I'll talk a little bit later very briefly about considerations around social determinants of health, which have become increasingly important in recognizing the impact that social determinants can have on someone's overall health status, and really, again, underscore the importance of thinking about healthcare at the community level and thinking about it from the standpoint of both healthcare as well as social service providers. We had a diverse group of participants at the summit. As you see here, a list of the numbers of types of organizations that were represented. Of course, the center did host the summit. We had representatives from a number of state offices of rural health, the Federal Office of Rural Health Policy, several hospital associations were represented, and then, of course, rural hospitals, ACO leaders, health researchers, a representative from Lutheran Social Services, and her perspective was great, as well as physician leaders and several healthcare consultants. And the report, as Terry mentioned, when that is published in the not too distant future, it does include a list of all of the participants, so you can see a little bit more then about the individuals and their backgrounds. So why focus on post-acute care? And Terry has really already set the stage for that conversation and has talked a little bit about why post-acute care has become an area of increasing focus over recent years. First and foremost is just the fact that we are experiencing both nationally and internationally an aging population. So a few statistics here. A recent report from U.S. News and World Report indicated the United Nations predicts that 1 out of every 6 people globally will be over the age of 65 by the year 2050. And the ratio is 1 in 5 in the United States. Particularly because of our aging baby boomer population and advances in medicine and technology, and Terry's already made some references to the impact that technology has had. The median age of Americans continues to rise, and I think the statistic that probably caught my attention the most of any of these is that the Census Bureau predicts that seniors will outnumber children by... Hello? Keely, can you all hear me all right?
Yep, we can hear you just fine. It was just someone's
background.
Yep.
Okay, some background noise. Okay. Yeah, I wasn't sure. So the Census Bureau predicts that seniors will outnumber children by the year 2035, and I found that to be a pretty astonishing statistic. One of the things that's important to recognize is that the percentage of older adults in the population varies considerably state by state. No surprise that Maine and Florida have among the highest percentages at 20% of their populations are age 65 years and above, to a low in Utah, among other states. So there's quite a range, and that has a significant implication for the healthcare delivery systems in those respective states. As you might expect, the aging population does directly impact demand on healthcare services and the need for healthcare services, particularly due to the high incidence of chronic diseases, the potential for injuries and fall risk for this population, as well as behavioral health considerations, behavioral health conditions. And all of that has led to, as I've already mentioned, for hospital systems, health systems, accountable care organizations, and health plans have really increasingly recognized the importance of post-acute care, really for 2 reasons. Both the importance of having a strong post-acute care component in the organization's delivery system and as a part of the care continuum. And then also, I both already mentioned the impact on total cost of care. Particularly as organizations increasingly are moving into a value-based reimbursement environment, issues such as hospital readmission penalties, the episode of care bundled payment arrangements that you are hearing about, and global payment models all really have made it essential for the organization participating in those sorts of reimbursement arrangements to pay attention to post-acute care and to be really attentive and to begin monitoring the cost and the quality of post-acute care services. The Center for Medicare and Medicaid Services, CMS, officially recognizes and defines 4 Medicare post-acute care sectors. And those are the 4 that you see here on this slide. In the most acute level of care and for individuals that require intensive rehabilitation would be an inpatient rehabilitation facility, the IRF. LTACs, the long-term care hospitals, are for individuals who need extensive rehabilitation typically. That can be individuals with, say, very serious wounds, or an individual who's ventilator dependent. They no longer need to be in an acute care hospital, but they require long-term acute care. And so the LTACs really emerged as that setting. The skilled nursing facilities, and home health are the most commonly utilized and are the 2 settings that we are all probably most familiar with. So those are your 4 CMS-defined post-acute care sectors. However, it's also really important for us to spend a little bit of time talking about swing bed services. While it is not, the swing bed program, swing bed services, is not included in those 4 official recognitions. Medicare does pay for covered swing bed services. And as many of you may know, swing beds, it's a defined situation that permits swing bed hospitals. It could be either a small community PPS hospital or a critical access hospital in a rural environment may participate in Medicare with approval to provide post-hospital skilled nursing facility care and meet certain other regulatory requirements for hospitals that to offer swing bed services. That is a Medicare Part A covered. Those are Medicare Part A covered services. And as I mentioned, specifically, swing bed services provide in rural PPS hospitals and in critical access hospitals. There are different mechanisms for reimbursement, as you see. There are requirements related to the bed size. In the case of a rural hospital, they have to have fewer than 1 bed, newborn nursery and intensive care type settings.
Excuse me, Louise?
Yes.
Your volume is kind of going in and out, so we can't, could you either,
okay.
Could you increase a little bit or talk closer to the mic? It's right on the edge, actually. I'd appreciate it. Thanks.
Okay. How is that? Is that better?
It is better, yes.
Okay, very good. I will hold it closer to my face. All right. So yes, and please do let me know at any point if I fade out or if it breaks up. One of the things, and Terry and I have talked about this was touched on during the summit, but one of the things that we thought would be really important to focus on briefly this morning is to talk a little bit about the value of swing bed services. There are some specific benefits to be gained as a result of the availability of swing bed services in rural areas. And you see several of those examples listed here. First and foremost is just that it increases access to skilled nursing facility level of care for Medicare covered individuals, allowing them to, in many instances, stay in their own or close to their own local community. And that may not be the case if they were having to look for a skilled nursing facility. because there can be a lack of skilled facilities in rural communities, which offers few choices then for families. So having access to swing bed services increases that access and that local availability. A second and distinct key differentiator for swing bed services or swing bed programs is that because those are hospital-based swing bed services, the hospital has available 24-hour access to physicians or other providers, physician's assistants, nurse practitioners, often who are helping to cover as hospitalists and are available on a 24-hour, 7-day-a-week basis, as well as on-site nursing staff and the availability of on-site diagnostic services, particularly lab and usually some radiology services. And that is not the case typically in a freestanding skilled nursing facility. So again, becomes a key differentiator for that hospital-based swing bed program. And lastly, and very importantly, swing bed services have really emerged as an increasingly important source of inpatient revenue for critical access hospitals. Nationally, inpatient admissions have continued to decline in recent years as more and more care and services shift to the outpatient care setting. And so in many instances, critical access hospitals have very low inpatient average daily census on the acute side, and so swing bed services are an opportunity to increase the census on a sustained basis. I wanted to say just a word about and talk a little bit about a couple of studies that have specifically compared and have looked at outcomes for care delivered in a swing bed program versus a traditional skilled nursing facility setting. Can you all hear me okay?
Yep, you sound good.
Okay, very good. One of the arguments that you will hear, and I certainly have heard this as I have been out and about working in various healthcare settings, and that is the idea that the cost per day of swing beds is so much higher than the typical cost per day at a skilled facility. And that is true typically. However, it is also really important to consider outcomes of care. To help to address that and to look at that, two studies have been recently conducted in Illinois and in Minnesota. The University of Minnesota Rural Health Research Center conducted a study, and also the Northern Illinois University Center for Governmental Studies did a study. Both were done in 2018-2019 time period, looking explicitly at outcomes and comparing skilled nursing facility outcomes and cost as compared to swing bed programs. Those studies reported that swing bed patient hospital readmission rates were lower than skilled nursing facility patient hospital readmission rates. And that's talking about individuals who are in or have been in a swing bed or a skilled nursing facility setting and had previously been in the hospital, then were in the swing bed or the skilled facility setting, and then went back to the hospital. The standard time period that's looked at is within 30 days. As I mentioned earlier, as healthcare organizations increasingly are moving into value-based reimbursement environments, hospital readmission rates, ED utilization rates are two of the key metrics that are closely monitored by organizations in a value-based reimbursement environment because of the implications and the impact on both cost and quality. In addition to showing differences in hospital readmission rates, the Illinois study in particular showed a significantly lower swing bed average length of stay of about 10 days versus the skilled nursing facility average length of stay over that same time period of 26 days. That's a significant difference in total cost of care, which again is really an important consideration in a value-based environment. These findings have really underscored by these two universities and these two studies has really underscored the importance of collecting and analyzing swing bed performance data to understand and accurately be able to report on cost, quality, and outcomes of care, which are really important in order for a swing bed program to be able to quantify and demonstrate their overall value. And one thing I wanted to share from the University of Minnesota report specifically is they stated up front that one of the purposes of their study was to identify measures that could be used to assess the quality of care, with the goal of having those measures ultimately endorsed by the National Quality Forum, which is one of the leading national organizations that looks at quality of care in healthcare. With a goal that these would be measures that would be adopted nationally as a way to begin to really look at and be able to compare quality and cost across these different post-acute care settings. So who utilizes post-acute care services? The most recently available statistics are in the 2016 to 2018 time period. In 2016, 57 million Americans were covered by Medicare. And as you see, about 2/3 still in the fee-for-service environment, but a little over 30% at that time in a Medicare Advantage plan. And those numbers have actually continued to rise in terms of the number of folks in a Medicare Advantage plan, which would be an example of a value-based reimbursement arrangement. A significant portion of healthcare is delivered in post-acute care settings, particularly for older adults, as you would expect. And approximately 43% of Medicare fee-for-service patients were discharged from an acute care hospital to some form of post-acute care, again, in 2016. That's actually recently published a year ago in the MedPAC report to Congress. They submit an annual report, and they are looking closely at cost and quality of various forms of healthcare delivery in this country. And Terry mentioned this in his opening remarks. This has been borne out by a couple of studies now showing a wide variance in the cost of post-acute care services across the United States. One of the very widely quoted reports, it's actually several years old now, the Institute of Medicine, but I see that their findings are widely quoted in healthcare literature around post-acute care. They identified post-acute care as the source of 73% of the variation in healthcare spending. That report and that finding back in 2013 really increased attention to awareness of and attention to both cost and quality of post-acute care services. I have often said that and this is really my opinion, but based on years of experience, that I think historically post-acute care has really been what I've called a red-headed stepchild as you think about the healthcare delivery system. And so some of these reports in recent years have really increased the awareness of and the attention to the importance of post-acute care. Similarly, September of 2017 MedPAC report found that post-acute care had the greatest cost variation across all sectors. That was looking at acute care, ambulatory care, and post-acute care. So as we've already mentioned, both Terry and I, a significant component of total cost of care is because of post-acute care service delivery. And I'm going to show you a graph here that shows these are the 4 Medicare recognized official Medicare post-acute care sectors. And this graph is showing spending, Medicare fee-for-service spending, total spending for post-acute care split out by each of those 4 sectors. I don't know how well you can see it, but at the top, the orange line on the graph represents skilled nursing facilities, and you can see a significant increase looking year over year over that 11-year period. The total cost had climbed to $25.3 billion in 2018, and that represented over over almost a 16% increase in spending over that 11-year period. The other thing that's important to note on this graph is that skilled nursing facility expenditures are consistently the highest cost post-acute care sector, representing almost 50% of all post-acute care fee-for-service Medicare expenditures. And they, as you can see, the two components at the bottom of the graph, inpatient rehab facilities and LTAC for the really most acutely ill individuals, those two subtotals to get combined are less than home health, and obviously considerably less than what the spending has been for skilled nursing facilities. So a lot of dollars associated with post-acute care. As a result, and based on both identified concerns related to quality as well as the significant cost associated with post-acute care, as you might expect, and because Medicare is a major payer for skilled care in this country, that has led to some pretty intentional focus by the federal government to address both cost and quality concerns. So that led to the passage in 2014 of the IMPACT Act, the Improving Medicare Post-Acute Care Transformation Act, which is quite a mouthful of a name. That act is really important for a couple of reasons. They've required MedPAC to consider and to report on the potential opportunity to develop a unified payment system for post-acute care providers. Currently, all of those four sectors each have a different payment system, different regulatory requirements, different eligibility considerations, and different cost and quality performance metrics. And so there is a strong interest now by the federal government in moving to some standardization, both on the payment side with the potential in the future of a unified payment system across all four of those settings and sectors. And then also the IMPACT Act, as you see, mandated the collection of uniform patient assessment information. One of the real challenges with post-acute care historically has been a real problem trying to make comparisons of quality across the different sectors and the different settings because of the variation in the quality metrics, the definitions of the quality measures, the actual data that was being collected has made it very difficult. It's really been like trying to compare apples and oranges and lemons to try and understand the differences from a cost and a quality standpoint. So CMS is moving to explicitly address that. They have done field testing, looking at a variety of potential standardized data elements to select. And it is my understanding that effective January 1st of this coming year, that multiple new standardized assessment elements will go into effect across the four sectors. And that will be the first time ever. A couple of other areas that I wanted to mention where there's been CMS focus, and that is, again, looking explicitly at skilled nursing facility and that sector, the skilled nursing facility sector. As I've already mentioned, that sector has represented the greatest cost for Medicare year over year for many years. And also, as Terry mentioned in his opening remarks, some growing concerns around quality. And particularly that's been true in the context of COVID-19, and I'll say more about that in a moment. But as a result, in 2018, CMS finalized a new case mix classification model specifically for skilled nursing facilities. It's called the Patient-Driven Payment Model. You may have heard of PDPM. That's become one of the new acronyms that is floating around. And that went into effect October 1 of 2019, so less than a year ago. And it did, as you see, they explicitly moved away from a volume-based to a more value-based reimbursement methodology. and stated explicitly that the new case mix methodology that they adopted through this new case mix classification model is utilizing clinically relevant factors, quote unquote, rather than volume of services to determine payments. That is a very significant shift. It particularly has impacted physical therapy and other therapy services in the skilled nursing facility setting. The other thing that I wanted to mention specifically, and I talked a moment ago about the importance of monitoring and the attention around reducing hospital readmission rates. And so in October of 2018, again in 2018, a lot really came to fruition at that time. And that was the CMS implemented a skilled nursing facility value-based purchasing program. And the first metric that they selected and is the current metric being monitored and addressed, and that is hospital readmission rates of skilled nursing facility patients. They are utilizing a specifically defined measure that you see there, which calculates a risk-adjusted rate of unplanned all-cause inpatient hospital readmissions that occur within 30 days of a skilled facility patient's discharge from a prior hospital stay. So they're looking at who bounces back basically within 30 days post a hospital discharge of skilled nursing facility patients specifically. And that is a value-based program, and that means that underperforming facilities, those who have a higher than expected readmission rate, receive a lower payment rate, a Medicare payment rate, than they otherwise would have if they weren't in this program. And all skilled facilities are required to participate in this program. It's not an option. And really for the first time, by making this payment change and identifying this specific performance metric, for the first time, really, skilled nursing facility alignment or reimbursement is moving into alignment with hospital and payer goals to reduce avoidable hospital readmissions. The hospital readmission penalty has been in place now for some years, but this is the first time that skilled nursing facilities are also now being measured and having a financial impact for high hospital readmission rates. So let's talk a little bit about the impact of COVID-19. And Terry mentioned this in his opening remarks, but unfortunately, and really very sadly to say, the current COVID-19 pandemic has heavily impacted both skilled nursing facility and assisted living facility residents. There have been high levels of infection, hospitalizations, and rates of death for residents in those settings across the United States. And in fact, the earliest outbreak out in Washington State involved a nursing facility. Earlier in the spring, Kaiser Family Foundation published some information saying that nursing homes and assisted living facilities accounted for approximately 41% at that time of COVID-19 deaths in the United States. And as Terry mentioned, some states have reported up to 80% of their total COVID-19 related deaths were attributed to individuals that were in post-acute care or assisted living facility settings. So just a really terrible impact on those settings of care. And very recently, last week, Health Affairs published a blog stating that more than 50,000 nursing home residents have died to date. And they also found, very similarly to the earlier Kaiser Family Foundation report, that deaths accounted for about 40%, nursing home resident deaths accounted for approximately 40% of all COVID-19 deaths. So a devastating impact, really, of this COVID-19 pandemic on that really vulnerable subpopulation. As a result of that, very recently, as well as some longer-term data going back to 2013 to the 2017 time period, there have been concerns around state and federal oversight, actually concerns around poor, weak state and or federal oversight. And Health Affairs talked specifically about as an example of that, the finding of 82% of nursing homes were found to have a deficiency in infection prevention and control during that time period. And almost 50% of those nursing homes were cited for deficiencies over multiple years. So not a single occurrence, not a one-time thing, but occurring over multiple years. And certainly those findings are very relevant in light of the impact of COVID-19 and the struggle to really try to control and reduce the spread of the infection of COVID-19 in those settings. As a direct result of the high levels of infection and deaths in nursing homes, in April, CMS announced the intent to form a new independent commission to conduct on their behalf a comprehensive assessment of the response by nursing homes nationally to COVID-19. You see here the administrator of CMS has said that the goal of the intent is to have this commission provide recommendations to quote unquote further enhance efforts at the federal, state, and local levels to really help strengthen the nation's response to COVID, the coronavirus, to COVID-19, and certainly to better prepare those facilities for what is certainly expected to be further episodes of COVID-19 and other types of serious infections on an epidemic or pandemic basis. This commission is on a fast track. The membership was announced in mid-June of 2020, so just a couple of months ago, and with the goal that they were to begin meeting immediately and to complete their report and present their report of findings to CMS by September of 2020. So we shall see if they are able to stay on that aggressive of a schedule, but that is the intent. I wanted to shift gears now, move away from the more general discussion about the background and the kind of what the current state is looking at post-acute care nationally, to talk more specifically about the summit. And a couple of these next slides take a look at a pre-summit questionnaire that all of the participants were asked to complete. And Terry and I thought that it would be useful to share a couple of the pre-summit questionnaire questions. So question number 3, by way of background, asked about trends. What did the participants think would be different as it related to post-acute care in the future, and to identify, areas that they thought would be different compared to the present. Question 4, which you see here, said, given the trends that were talked about in question 3, what are the 5 important forces driving those anticipated changes? And so that's what this slide is showing. And as you see, the top 3, in fact, they were tied, and the same number of individual participants selected those 3, increased emphasis on quality and value, payment, and the increasing use of technology, all 3 of which Terry and I have both already touched on in our remarks today. And then the other question that we thought would be interesting to share, and that is the participants were asked as they looked out over the next 10 years, what did they identify as the 5 major challenges that rural post-acute care and aging service providers would face. And as you see, the top winner, if you will, the top example that was identified was staffing turnover, difficulty recruiting and retaining staff, and a lack of medical providers and specialists, in particular specialists in gerontology in the rural environment. And those were the top 2. And then the third challenges around reducing cost of care. So access to staffing, providers, and then continuing concerns about cost of care. Broadband then came in behind as 4th. So again, carrying forward that technology focus. So following a review of the questionnaire results, the summit participants then we really boiled it down to say, okay, what are 4 high priority areas that have emerged that are really important for some further attention and a deeper dive? And so we were moved into 4 breakout groups, and the 4 topics that were selected, no surprise, based on some of what we've already talked about, and that is payment, both hospital coordination as well as community level of coordination among the parties, in particular, again, focusing on post-acute care and hospitals, rural hospitals, and then 4th, workforce. So each of these 4 breakout groups then spent time looking at issues and challenges relating to those 4 topics and identifying potential strategies, solutions, and action steps. A number of common themes emerged across these 4 breakout groups, as you see here. Again, reimbursement and the changing reimbursement environment. Again, the ongoing shift that's occurring, moving away from traditional volume-based fee-for-service and cost-based reimbursement. The critical access hospitals, of course, being cost-based reimbursement currently, and that transition that's occurring as organizations move to value-based reimbursement arrangements. Again, here we go, another time, need to improve access to care and services, the evolving role of technology, workforce challenges and opportunities. And lastly, and as I mentioned earlier, recognizing the importance of addressing social determinants. Those were really the themes that emerged out of all of the 4 breakout sessions and those discussions. I won't spend a lot of time on this because I see we're running out of time, but we looked at a number of considerations related to payment and opportunities for payment reform. Again, you see issues around reimbursement and technology. A number of recommendations ranging from, again, kind of national big picture policy, paying for the use of technology. I thought this one was really important, that bullet 2, paying for the use of technology to serve patients both in long-term care setting, but also to better utilize technology to help keep people out of the institutional setting and to make it possible for folks to stay in their homes as long as possible. Telehealth and home monitoring would be examples of that, and really utilizing technology to support those avenues. Again, social determinants of health, that's looking at things such as individuals' access to transportation, safe, affordable housing, ability to access health care. And then another suggestion or recommendation was to look at funding in the post-acute care sectors for chronic disease management, which I thought was an excellent point. A few others here related to payment recommendations. One very practical, very actionable item requiring post-hospital discharge calls for individuals that are discharged to a nursing home setting as a way to really gauge their condition and their progress, and to help to avoid ED visits and hospital readmissions. The hospital coordination group identified a number of challenges, as you see here. Again, one of the particular concerns around lack of challenges around integration with behavioral health and primary care, silos of care, different systems from a technology standpoint, lack of ownership and engagement around the role of coordination among the parties. And then again, looked at some particular recommendations and solutions. Increasing the use of mid-level practitioners, nurse practitioners. One opportunity that some hospital systems and health plans have adopted, and that is that in that center, adopting or a model that utilizes hospital-based physicians to become medical directors of local skilled nursing facilities. That really has served to increase communication and coordination, collaboration between the hospital and the skilled facility, to improve transitions of care as patients move from one setting to the other, and is also a way to strengthen the quality of care in the skilled facility itself. SNFist model is terminology you may hear, and that's really taking that idea of having physicians that are assigned to and provide direct on-site, increased direct medical care, typically utilizing nurse practitioners or PAs to as members of a team delivering care on site in the skilled facility setting. We also then, as I said earlier, looked at community care coordination and looked at similar kinds of elements, concerns around fragmentation, lack of understanding of resources, scarcity of resources at the community level. Again, concerns around transitions of care. The group identified solutions to help to address some of that. One I wanted to call out was, again, identifying and addressing priority health needs of the community in an organized way, which then helps the community to be able to hone in on and develop strategies and actions to address those gaps or those areas that are lacking. And then lastly, post-acute care workforce was the fourth breakout group. As we've already mentioned, that clearly emerged as a major concern. High rates of turnover have been a challenge in the post-acute care sectors, particularly in skilled nursing facilities for a number of years. Wide variation in nursing scope of practice. And then again, as we've already mentioned, real challenges around recruitment and retention and training. One specific recommendation that came out of that work that I wanted to call out, and that was investing in staff through something such as a pathway for growth, which is really, and there's an example of that in the resource slide at the end of the deck for you all to reference. But looking at helping to develop really a career path for employees, helping them to not only strengthen existing knowledge and skills, but also helping to prepare those individuals for future career growth and opportunities. So I would encourage you to take a look at that. And that does bring me up to the resource slide. We've included a link to both of those studies that I talked about in discussing the swing bed versus skilled nursing facility comparison. Would encourage you to take a look at those. Very good discussion about potential quality metrics that can be adopted nationally to really help to monitor and compare quality and cost across these settings, and then the pathways for growth. And that does bring me to the end of the presentation. My bio is here and my contact information is available. Certainly if any of you have a question about anything that I've discussed today, feel free to reach out. And Terry, I haven't left very much time, but I think we've got about 6 or 7 minutes here for questions that if there are any from the audience.
Terrific. Thank you, Louise. I've taken a lot of notes. That this is really an excellent presentation. The information that we're talking about, it strikes me it's driven by two major forces that seem to have been exacerbated by the COVID pandemic. One of them is obviously quality. We've known, you've called it a red-headed stepchild. It's always, the other companion, by the way, is mental health. These are sectors of our healthcare system that consistently have been moved to the back burner. In both these cases, they're now up front. So it's the quality issues, but it's also the payment issues in that regard. And do we have any questions from the audience here before? I have several, but let's let the audience ask if they have them. You can either unmute your line and ask, or you can ask the question in the chat box. Well, let me start with a question then, and that is, given the fact that we have an extremely high cost in our skilled nursing facilities, and we now have a new ability to use telehealth and actually getting paid for monitoring of older adults, and we have this movement towards aging in place and aging at home. Do you see that there's going to be a real impact on the skilled nursing facilities? May we, in fact, see a movement away from skilled nursing facilities and increasingly into home care, home monitoring, et cetera?
Terry, I think that's a really good question, and I know we actually talked about that a little bit during the summit. I think there probably will be some move in that direction. I do think, however, the reality is that there is certainly a subset, those individuals who are not in a skilled facility for short stay rehab, who, for those individuals, the goal is to help them to improve their functional status and to regain strength, what have you, and be discharged back to the community setting. I think the real ongoing challenge will be those individuals that are in the long-term care side of the house, if you will. And for those individuals, in so many instances, it is a situation of physical decline and frailty as well as dementia. And that population really does require 24-hour-a-day, 7-day-a-week care. And I think I personally think that there will be an ongoing need for some institutional level of care for those individuals. I do think there is and we've touched on it today, but certainly home monitoring and telehealth and more fully utilizing home health services and other home and community-based services are all intended to make it possible and to provide wraparound supportive services to keep individuals in the home setting as long as possible. So I think that we will continue to see a combination. Some state Medicaid agencies in recent years have made a very concerted effort and have, kind of reorganized the reimbursement to promote the increased use of home and community-based services as an alternative to institutionalization because of the cost and quality considerations.
And Louise, home care is often a service provided by rural hospitals, but I know it doesn't make a lot of money for the hospital itself. In many cases, the geographic situation means that we have to drive a lot of miles, et cetera. So I think what's going to be emerging here is a greater emphasis upon home care, that payment is going to line behind it, and particularly using telehealth. As you said, the comorbidity between some of the diseases associated with aging and things like depression and dementia, et cetera, are going to call for greater emphasis on the institutions. But increasingly, it just seems the payment system is starting to align behind keeping people in their homes, and particularly if the telehealth is paid for, which to me, it's absolutely going to happen. We're seeing it already. United Healthcare is talking about trying to do all the urgent care remotely, et cetera. So the president's order that just came out a little over a week ago basically talked about making permanent the telehealth payment advances that had been kind of standing in the way of using telehealth in the past. So I would agree with you. We're never going to get out of needing institutions, but I think the emphasis is entirely on moving more towards that virtual care.
I think that's exactly right, and there is some data to show that for ACOs and particularly for health plans, that shift has been happening.
Yep.
That there has been a direct reduction in the utilization of skilled nursing facility setting and a corresponding increase in home health services. Yeah. That trend has been happening.
Terrific. I want to make sure that I thank the Nebraska Office of Rural Health, who provided the funding for this 4-part webinar series. I personally have learned a lot. I thank those of you that have attended not only this session, but our past sessions. I want to thank particularly Nancy Johansson, who is the Flex Coordinator, and Margaret Brockman, who's the head of the Office of Rural Health in Nebraska, for their support and their input on these sessions as well. And Louise, I want to thank you very much. This was an excellent session, and I want to then kind of conclude this seminar and wish you all a good day and the rest of the week. Bye, everybody.
Thank you so much, Terry. Appreciate it.